What time does this session start? Guess we should get started. It's already 2 minutes through. It's working. All right. Aloha. My name is Yuzo Kodama from Kobe University, and I'm very happy and honored to be here as a chair with Professor Koch, Koch, Professor Koch. And the session title of this our session is Unlocking Hope, Advancements in Early Detection of Pancreatic Cancer. And we have 4 talks. And first, we have 4 talks for presentators. And then we have Q&A session for like 15 minutes. So please introduce first one.
Oh, well. So welcome, everybody. This is one more session in a series of terrific sessions that we've had here. And the first presentation is by Dr. Arthur Singhi from the University of Pittsburgh Medical Center. And go ahead.
Yeah, so I think I have 15 minutes, but I've already lost a few. So I'm going to try to go through this quickly so we can stay on time. And the unfortunate thing is I can't cover everything when it comes to IPMNs or cyst pancreatic biomarkers, but I would like to provide a brief overview of the current problem, where we are now, and actually, in my opinion, where I think we'll be or will have to be in the future. But let's start first with the case presentation. And I don't really like case presentations overall, but I think it does fit a purpose in this talk. And that's a 60-year-old male presenting with an incidental cyst after the workup for chest pain. The cyst was 1.6 centimeters, located in the pancreatic body, and the EOS was consistent with an IPMN. Unfortunately, on FNA, cytology wasn't very helpful, and CEA testing wasn't elevated. Molecular testing at the time was indeterminate with a low amplitude alteration at chromosome 1p36. I have to fully disclose that this is not an assay that's done at UPMC, but it was done in 2008. But importantly, no KRAS mutations associated, at least with mucinous cysts, were identified. The patient did have a CT scan 4 years prior, and the CT was actually, the cyst itself, based on that CT scan, actually showed the cyst being present even back then. And follow-up imaging in 2009 and then 2011 also showed cyst stability. Now, when it comes to pancreatic cysts, I would say this is a fairly common scenario where there's still unanswered questions. Should the patient continue or maybe discontinue surveillance, especially considering the stability itself from 2004 theoretically to 2011? Or should another EUS-FNA be performed due to the inherent nature of the cyst itself, the lack of molecular alterations, at least at that time, and the fact that there was no elevated CEA, and the unfortunate issue of cytology? But the real issue among these, honestly, that when it comes to pancreatic cysts is that we all know that really about 60,000 Americans present every year with a pancreatic cancer, and about 15% are presenting with a pancreatic cancer arising of a pancreatic cyst. But the other issues we also know in parallel is that pancreatic cysts are very common in the United States. Actually, the most predominant cyst, unfortunately, is IPMNs, which we also know are precursors to pancreatic cancer, such that identifying IPMNs that will transform into pancreatic cancer is like looking for that proverbial needle in a haystack. That being said, upon the identification of pancreatic cysts, and I'm probably preaching to the choir here, but a multidisciplinary approach is needed that includes clinical presentation, cross-sectional imaging, endoscopic ultrasound or EUS, and a key component of pancreatic cyst fluid evaluation, which is aspiration of pancreatic cyst fluid for ancillary studies such as CEA, glucose, cytologic evaluation. CEA and glucose are markers of mucinous cysts. Cytology can certainly aid in the detection of malignant cells. But as shown in a recent meta-analysis that was discussed this morning, that really helps support the Kyoto guidelines, all three have their limitations in sensitivity as well as in specificity. Thus, the need for better or additional pancreatic cyst fluid biomarkers. The problem is when it comes to biomarkers, take your choice. I mean, there's a million of them that have been reported, and honestly, maybe about 10 to 15 are reported every week when it comes to pancreatic cancer, pancreatic cysts, and the ability to early detect pancreatic cancer, such that it begs the question whether really the juice is worth the squeeze. The question really becomes is, do we have cyst biomarkers ready for real-time analysis in the present and not necessarily in the future? Are they ready for clinical use? Nevertheless, really in the last few years, I think that there has been some exciting work in the field of pancreatic cysts that has emerged from DNA-based sequencing. For instance, among the major pancreatic cysts, numerous studies have reported distinct mutational profiles that are highly specific for cyst type. For example, IPMNs can harbor KRAS and GNAS mutations. In addition, serous cystadenomas can harbor VHL alterations, while non-neoplastic cysts are pretty much devoid of all the above alterations overall. In fact, based on these findings, one could create a very sensitive and specific panel that can be used to assay preoperative pancreatic cyst fluid. In addition, as I mentioned before, not all mucinous cysts will progress to malignancy. In fact, it's a very rare phenomenon overall. And despite refinements in cyst guidelines, really both evidence-based and consensus-based, there are still issues with sensitivity and specificity in predicting advanced neoplasia. However, gene sequencing studies have identified recurrent alterations associated with high-grade dysplasia and cancer and mucinous cysts. To name a few, these include P53, SMAD4, PIK3CA alterations that can be also added to the list, such that we now have a group of genes that characterize mucinous cysts and, more importantly, their malignant potential. Now, in parallel to the genomic discoveries that really form the basis of understanding the progression model of IPMN-associated pancreatic cancer, so too have there been discoveries in the ability to evaluate specimens to kind of really leverage that data. And that includes development of assays, such as the PANDA study, which is probably one of the primarily the largest ones that were initially kind of moving forward with the ability to do this in real time, that evaluated KRAS, DNA quality and quantity, and LOH at 10 genomic loci. Thereafter, actually, I should take that back, is that actually that was the same assay that was used in our case presentation in 2008 of that 1.6 centimeter cyst, and actually set the standard initially when it came to clinical-based testing. But since that assay or that PANDA study itself, certainly we've seen an evolution of different assays or different biomarkers being added on. That includes not only KRAS, but GNAS alterations. In addition, the combination of GNAS and KRAS with next generation sequencing, such that we're now at a point of a multimodal assay when it comes to molecular alterations at the DNA level, and eventually culminating into what we believe is actually honestly the next step, which is really a multi-institutional observational study to evaluate patients in real time and utilizing, in this case, a 22 gene panel called Pancreas-seq. This was offered actually to gastroenterologists from actually 31 institutions. Over 800 patients were evaluated. This included, honestly, a significant amount of work overall, trying to obtain follow-up for patients, also including a 3-year long-term follow-up, as well as diagnostic surgical pathology for those patients that had surgical resection. I think that one of the issues or one of the results that came out of this observational analysis was that certainly molecular alterations can be useful in the identification of mucinous cysts, and that being both IPMNs and MCNs, primarily IPMNs with a sensitivity of 90% and a specificity 100%. And as discussed this morning, that assay also developed, showed an 89% sensitivity and a 98% specificity for advanced neoplasia. But I think that one of the things that came along around for the ride was that we were making observational analyses as we started doing a lot of patients in real time, and we identified things that we didn't expect. And that's the identification of fusion genes, especially those that are associated specifically with high-grade dysplasia and the development of pancreatic cancer, such as PRKACA and B fusion genes that are associated specifically with intraductal oncocytic papillary neoplasms. IOPNs are precursors, just like IPMNs, to pancreatic cancer, and they're always universally associated with high-grade dysplasia, and 30% give rise to pancreatic cancer. Additionally, what we found was that it wasn't just the presence or absence of a mutation, but the ability to quantify a mutation that also provided some additional data. In other words, let's say you had mutations in KRAS and GNAS, and we know that these alterations are associated with an early driver of IPMNs, and in the absence of other alterations associated with low-grade dysplasia. But in contrast, when you start developing alterations in P53, SMAD4, et cetera, these findings correlate with the presence of advanced neoplasia, such as high-grade dysplasia and cancer. But in certain instances, you have a dichotomy or discrepancy when it comes to the allele fraction of GNAS or PIK3CA or P53. And interestingly enough, when that discordance occurs, that actually correlates with low-grade dysplasia to a pathologist. And that's what we believe are the high-risk patients. These are the patients that are more likely going to eventually transform, at least within their lifetime, or maybe not in their lifetime, but at least the ones that we want to survey closer than others that don't have any of the low, or rather the high-risk alterations, but at a low-risk frequency itself. Certainly, we have seen cases now following these patients. Again, that study ended in 2020, and now it's been at least 4 years. And we've seen even this patient that had a low-level P53 in addition to a KRAS mutation that eventually progressed into pancreatic ductal adenocarcinoma. Sadly, again, these are very observational studies overall. We haven't done an interventional trial to truly determine the implications of these alterations overall. But I do think that it leaves us a window that we all really need, and that's cyst monitoring or surveillance. One of the issues with molecular testing is it tells you at a static time point. It tells you what's happening at the time of an FNA. But what we need from the molecular testing is not just the diagnostic portion, but the ability to eventually classify cysts over time and to identify, in a precision-based medicine, the ability to do surveillance and how to design surveillance protocols thereafter. I would say that that's not where it ends. I think that that's only really the beginning. And that's where, again, the abstract that was mentioned this morning, and that's where we're getting into now RNA-based testing, where we're now pushing forward with another study, this being observational itself. It was mentioned that about 4,000 patients were done. That's actually now, if you update those from the abstract, we have actually included about 6,500 patients from 47 institutions. This is an international study, includes Canada, Mexico, and other countries in Europe, as well as outside of Europe. And so we are now accruing the follow-up from these patients, and I'm hoping to publish that very soon. But let's go back to our patient that, again, in 2008 had was again a 68-year-old male, 1.6 centimeter cyst, actually identified in 2004 if you look retrospectively, and then in 2011 really showed stability. You literally have 7 years of stability overall of this pancreatic cyst. Now, what we've been doing at University of Pittsburgh Medical Center is we have been retrospectively going backwards, looking at our biospecimens, looking at our patients, looking at the cyst fluid, and retesting on our newest panels. And what we found in this patient, testing that 2008 specimen, was a PRKACA fusion gene, which again, I mentioned is associated with IOPNs and universally harbor high-grade dysplasia, and 30% have an associated cancer. Again, this is at a time when it was 1.6 centimeters, and based on that molecular profile, we asked the gastroenterologist to call the patient back, come back for surveillance. That cyst now has grown to 6 centimeters. Without that, we would never have known what was going on in that patient. That patient was referred to surgical resection, had a distal pancreatectomy for a 6 centimeter IOPN with beautiful papilla involving the main duct as well as the side branches, and extensive high-grade dysplasia demonstrating complete anisonucleosis, prominent nuclear atypia throughout the cystic lesion overall. Thankfully, no adenocarcinoma was present, but we know the genetic programs of these types of cysts. So back even in 2004, even though it was 1.6 centimeters, knowing that it was a PRKACA fusion gene, we could have predicted what would have happened in the future 20 years later, maybe even sparing that patient a smaller resection than was done right now. And so I've covered a lot in a very small amount of time, and I have less time to begin with. But I think that we are at the cusp of the point of applying next generation sequencing to pancreatic cyst fluid specimens. If you're going to do an FNA of the pancreas or the pancreatic cyst fluid itself, why not send for molecular testing? You're just getting additional data. So I personally believe if you're going to do an EUS FNA, send it. The question now becomes is what do you send for? Do you send for certain genes? Do you send for RNA-based testing? And I think that's going to progress over time as about what the ideal criteria or what biomarkers within a molecular profile should be done. But I would say that we are getting to the point where inclusion of RNA-based testing is going to improve the detection of high-grade dysplasia and early pancreatic ductal adenocarcinoma, as well as quantifying the mutations. Not just the presence or absence is going to have a huge impact on surveillance. I would say where the future belongs is really answering a lot of questions. And that is really who to test. Is repeat testing necessary? How often should we test? What about surveillance? How do we integrate these into current and future guidelines, especially as we're on the cusp also of the global pancreatic cyst guidelines? And there are other applications, other hard to treat areas or hard to diagnose areas, difficulties like bile duct strictures, main duct lesions itself, neuroendocrine tumors. And I think that's where we can continue to apply molecular testing. Now, I mentioned that we started with DNA and now we're evolving to RNA, but we're not going just RNA. I think now we can do whole transcriptome, and actually that's the next step for Pancreas-seq, where it will implement whole transcriptome sequencing of pancreatic lesions. And to date, we've now done 389 prospectively. And with that, I will end and just say thank you to all of the collaborators, all the people that have submitted for Pancreas-seq, the funding agencies that have really generated, really just been very generous with their time and their support for development of clinical assays. Thank you.
Thank you very much, Dr. Singer, for this outstanding presentation. There are no questions now because we're going to have a panel discussion. Can the person with the computers in the back, can you guys eliminate the echo that we keep hearing? The next speaker is Dr. Somashikar Krishna from The Ohio State University, and he will be speaking about early detection of advanced neoplasia in IPMNs using novel confocal laser endomicroscopy and artificial intelligence.
I thank the organizers for giving an opportunity to present our research. So branch duct IPMNs are known precursors for pancreatic adenocarcinoma. Approximately 15 to 20% of pancreatic cancers could start as branch duct lesions. Now, despite guideline-based recommendations, there continues to be high rates of resection of branch duct IPMNs. Up to 60% of branch duct lesions resected in various published studies can show only low-grade dysplasia, which is not the ideal outcome. Because of suboptimal diagnostic tools, there have been multiple guidelines. The latest guidelines published in 2024, the Kyoto evidence-based guidelines, is the first time it's called evidence-based compared to prior consensus guidelines. Now, we just listened to this excellent talk on molecular markers. This talk will focus on an imaging modality that is confocal laser endomicroscopy. So what is confocal endomicroscopy? This is a tiny mini probe which is introduced through the 19-gauge needle. And once the needle is in the cyst, you advance the probe beyond the needle tip, then you can touch the epithelium of the pancreatic cyst to get a continuous microscopic video from inside of the cyst. Endomicroscopy has unique image patterns for diagnosing specific pancreatic cyst types. The big benefit is that it provides real-time diagnosis by in vivo imaging. There are two critical things which endosonographers need to be aware of. One is that there is a learning curve to learn the procedure, so technical aspects to get high-quality imaging. The second is interpretation of the images. We did do a study where we had 21 freshly minted advanced endoscopists, and we trained them, and we saw that about 40 videos. After they reviewed 40 videos, they reached optimal learning with a 2 to 3 month durability as well. Now, single center and multi-center studies have consistently shown that endomicroscopy can differentiate mucinous and non-mucinous cysts with an accuracy above 97%. In this latest update from our ongoing multi-center study in the US, which is the CLIMB multi-center study, just got 14 centers, 17 endosonographers, the differentiation stays beyond 95%. So also in the CLIMB study update, we see that to diagnose specific cysts, the overall accuracy ranges from 94 to nearly 100%. Multiple training and inter-observer studies have been performed, and we have shown that endomicroscopy patterns are easy to learn. And so also there is high level of agreement among observers and also high level of accuracy. Now, the rest of the talk will specifically focus on IPMNs. In the center, you see a classic papillary structure seen in IPMNs. There is an inner vascular core and an outer epithelium. And on either side, you see endomicroscopy images of this papillae. Two big differences. One is it's black and white. And the second is the resolution is not as good as histopathology. It's no match to histopathology. But the big benefit again is that you can appreciate this papillae, the morphology of this papillae in the pre-surgical setting in vivo. And you can appreciate this papillae all through the cyst to come up with some diagnostic prognostication. When you look at this papillae, now these are papillae from different patients, what you see is that there is quite a bit of heterogeneity. There are different sizes, densities, shapes, configurations, and so also different levels of epithelial thickness and darkness. Now, here is a quick kind of a slide which shows how this papillae progress through low grade achieving adenocarcinoma. These are from different patients, of course. So in the center, you have a classic papillary structure, inner vascular core, outer epithelium. And then as the dysplasia progresses, there is stratification of cells and nuclei. It's multi-layering. And since the nuclei gives a dark color, there is more darkness and there is thickness of this papillae. And as you see, the lamina propria, the vascular core, is now encroached by these cells and this obliteration of the lamina propria. So also the borders become diffuse and hazy. So the papillae lose their architecture. And in the next, you see that the papillae have pretty much lost their architecture. And in the center, you see a large malignant cell with a prominent nucleus. So also, you see complex vascularity. There is neovascularization, so you appreciate this complex vascular networks as well. So these findings are quantifiable. So what do I mean by that? So in the top panel, here you see endomicroscopy and corresponding biopsy. This is low-grade dysplasia. You see that the epithelium is thin and it's monolayer. But then once dysplasia has progressed, in simple terms, there is increased darkness, increased thickness of this epithelium because of cellular stratification. Some more differences. So in low grade, on your left, you see the epithelium are flat, thin, translucent, and pretty small. On your right, you see high-grade dysplasia, where the papillae are thicker, larger, and more solitary, occupies the entire visual field, and also darker with loss of the vascular core. You can appreciate all these configurations changes in a pre-surgical setting, and here is a video in real time. And I'm going to play these videos so that you can kind of feel dizzy for a second. But the idea is that these images move very quickly because of two reasons. One is the patient is constantly breathing. So you got the EUS, the needle in the cyst, you got the probe at the end of the needle, and the patient is constantly breathing. Because of that, the video moves pretty fast. And so also these papillae are floating around in the mucinous fluid, which also has that movement with the breathing. So the morphology is very heterogeneous. No single papillae looks like the other papillae. And then the frame rate is pretty fast at 12 frames per second. So it's challenging for the human eye. And a single video up to 10 minutes can have thousands of frames, and every frame matters. Because of this, we started working on an AI model back in 2019. We initially used edited videos, high-yield videos to train the AI model. Subsequently, we have developed fully functional AI algorithms over the last 4 to 5 years. Now, in simple words, just to kind of really kind of break it down, on the top panel, you see endomicroscopy video broken down into frames, and the AI model, within seconds, picks up these papillary structures, measuring various parameters. Some parameters are pre-fed by us. Some of these, the AI learns on its own from the training. So again, here is how the AI works. We call it NCLE AI. You take an endomicroscopy video, which is unedited from the patient, and then it's fed to the program. The program goes through a classification where it'll pick up epithelium, papillae, sensible structures, and then it'll reject structures which don't have value. And once it looks at these structures, which are papillary structures or thin epithelium, it classifies them into 3 levels of dysplasia. This is completely different from the pathological classification, either the pre-2019 or the post-2019, which is initially it was low, intermediate, high. Now it is low and high. But this is totally different. This we have developed because what we get with the preserved interstitium from inside of the cyst is very different from what the pathologist sees in a post-resected specimen. So the AI classifies them into 3 degrees. These can be, the output from these can be a continuous variable if somebody wants to. The reason is we want this AI model very flexible so that we can add other diagnostic predictors. It could be Kyoto variables, it could be clinical features. You can use them in a logistic regression model, eventually to have a patient outcome where it classifies that as low grade or high grade. So to this effect, we conducted a study. We wanted to compare humans to AI, like a lot of studies where we compare humans to AI. So we took 60 resected branch duct IPMNs with histopathology. We sent the videos, unedited full-length videos to 16 human observers across the world who have experience in endomicroscopy. And then in parallel, the AI model also looked at these videos. And we compared the diagnostic accuracy to differentiate low grade versus high grade. Subsequently, after each case, the human observers were provided the Fukuoka variables because this was right before the Kyoto update. And then we fed the same variables to the AI model, and we compared again the diagnostic accuracy to differentiate low grade and high grade. And if you compare just using endomicroscopy imaging, the AUC for human observers was 0.6, comparatively AI was 0.7. Once you add the Fukuoka variables, humans achieved an AUC of 0.64, the AI was 0.85. At that AUC, the sensitivity specificity was equal at 78%. The AI also achieved a higher accuracy than the Fukuoka high-risk stigmata. Now, how can we further improve the AI? Now, as I briefly alluded to regarding the vascularity, since there is neovascularization, on the left column, you see high-grade dysplasia with complex vascularity. On the right, you see more simple or what we call as rope ladder type vascularity. So we are training the AI model to include vascularity as well. Now, our future plans also include to incorporate other clinical data, patient variables, imaging data, cyst morphology, molecular analysis data to create an integrative AI algorithm. And so also this we are kind of trying to implement now where we upload this AI algorithm to a cloud server and centers. We have about 15 centers on our multi-center study. They can upload their endomicroscopy video and get a kind of a real-time decision. This is part of a study, so it's not FDA approved. And over time, what's going to happen is the AI model is going to improve. There is a self-learning AI program, much like people who use Tesla and use that FSD. So how it improves over time. So briefly, these are the milestones. We started with edited videos. Subsequently, we took full-length videos, and then we integrated Kyoto variables. Our future plans is to further improve the AI model, integrating a multi-modality diagnostic testing. Now, why is it important? Other than surgical decision-making, why is dysplasia grading very important? Now, in the last few years, we have seen several papers using chemo and some case series using thermal ablation of IPMNs. And dysplasia classification, or accurate dysplasia classification, is very important when you consider cyst ablation. In 2 slides, I want to explain our experience using RFA for ablating IPMNs. And here, this is called the ARRAISE study. It's a single center study, which we started about a year and a half back. We take IPMNs, which are more than 3 centimeters, discuss them in multi-disciplinary tumor board meetings, and we do offer ablation to patients who are deemed to get surgery, but they are not surgically fit, who have older age or prohibitive surgical risks. And here is how ablation is performed. You have a cyst, a branch duct IPMN, complex septations, about 4 centimeters. You identify the pancreatic duct, try to stay away from the pancreatic duct. First step is to aspirate the cyst completely, aspirate all the compartments. And you want to leave a small target because that aspiration needle is withdrawn. And then you pick the RFA probe, which is a 19 gauge probe. And then you go to that small target, and you can actually reach the other areas of the cyst, but you don't really need to apply ablation to all the parts of the IPMN. And ablation is applied till you see white bubbles or if there's a spike in impedance. And you try to approximate as much of the cyst epithelium as possible, and subsequently the needle is withdrawn. So in one slide, we want to summarize our study results. We have ablated 30 IPMNs, branch duct IPMNs, mean size of about 4.5 centimeters. And if you define complete response as just volume reduction, it's more than 90% volume reduction. It's a 37% response rate. But then what we are seeing is that there is a pseudocyst type reaction. And when we aspirate the cyst, we see complete loss of mutations. So if you say clinical response as loss of mutations or more than 50% volume reduction, our clinical response is at 92%. Again, this is an ongoing study at this time. Of course, we need long-term data. That being said, this brings us to the last slide. Endomicroscopy is highly accurate in diagnosing IPMNs. Integration of AI improves risk stratification of IPMNs, and this should have clinical impact, significant clinical impact. Potentially, we should refine diagnostic algorithms and include endomicroscopy in clinical practice, specifically when managing cysts which are larger. And so also this would potentially encourage endoscopic management of branch duct IPMNs in select patients. With this, I'm immensely grateful to all the funding societies, and so also highly appreciative of our entire division at The Ohio State University. Thank you.
Thank you, Dr. Krishna, for an outstanding talk. No.
Okay, so let me introduce next speaker. Next one is Professor Kenji Takahashi, my friend, from Asahikawa Medical University Hospital. He's gonna talk about the clinical application of extracellular vesicle encapsulated RNA panel as a liquid biopsy for pancreatic cancer diagnosis. Please.
Thank you, Chairman. My name is Kenji Takahashi from Asahika Medical University in Japan. Today, I'm going to talk about the clinical application of extracellular vesicle encapsulated RNA panel as liquid biopsy for pancreatic cancer diagnosis. Okay, sorry. The slide shows COI disclosure. So we have focused on the function of long non-coding RNA in pancreatic ductal adenocarcinoma, PDAC development. Long non-coding RNAs are defined as non-protein coding RNAs more than 200 nucleotides in length. Although long non-coding RNA can contribute to many biological processes, their contributions to PDAC are not well understood. This slide shows a list of representative long non-coding RNAs in PDAC. Among them, we focused LINK-ROR, HALK, and HEBEPAM, and have recently investigated the regulatory roles of PDAC development. Extracellular vesicles, EVs, are released by most of the cells and are broadly classified into three main classes: microvesicles, exosomes, and apoptotic bodies. We have previously reported some microRNA, and long non-coding RNA could be transferred by EV from their donor cells to recipient cells and affect cell signaling and phenotypes. The slide shows the percent of cases and 5-year relative survival by stage at diagnosis in United States are shown. 5-year survival of localized PDAC was about 44%. In contrast, in Japan, 5-year relative survival of tumor less than 10 millimeter is over 80%. Thus, early diagnosis of PDAC could be essential to improve the prognosis of patients. Recently, for early detection of several cancers, circulating tumor cells, cell-free DNA, and cell-free RNA, EVs, are focused as liquid biopsy tools. We have recently investigated the multi-layer detection using cell-free DNA, RNA, and EVs. I'd like to show the one of our collaborating research. This is a report from Tottori University in Japan, our collaborating research institute. Secretin administration can improve the accurate diagnosis rate of pancreatic juice cytology. Thus, we are trying to improve the accurate diagnosis rate of PJ cytology by adding our DNA and RNA analysis. This project is one of our liquid biopsy project and supported by the Japanese Society of Gastroenterology. On the other hand, in this project, we focused and used blood samples and aimed to identify candidate genes using our system to establish eVRNA panel for PDAC diagnosis. Serum samples of 29 healthy individuals, 25 patients with IPMN, 21 without worrisome features, and 7 with worrisome features, and 25 PDAC, total 82 samples were obtained at the Asahikawa Medical University Hospital in Japan from 2021 to 2023. All patients were histologically confirmed and TNM classification and stage are defined according to the UICC classification. EV are isolated from 1 milliliter of each serum using our generated EV isolation method, EV step. Then EV RNA was isolated, RNA sequence data was obtained or using NextSeq 550 system. Finally, bioinformatics analysis was performed. Although the standard method of EV isolation was repeated lateral centrifugation, we developed the EV isolation method from body fluid. This slide shows the illustrate of the our generated new EV isolation method termed EV step-based immunoprecipitation. Optimized EV step reagent can dissociate the substance from EVs, making it easier for antibody to access and trap EVs. Same image indicate large particles are magnetic beads and small vesicles bound to their surface are EVs. EV step can improve to isolate EVs with high quality and quantity. So using these new methods, we have some results, and I will show the results in order. The slide shows the quality check of eVRNA sequencing. Left graph shows the number of mapped leads, And center graph represents transcript counts with transcripts per million over 1. The distribution ratio of mapped transcripts for messenger RNA and long non-coding RNA exceeded 70%. The results of differential gene expression leg analysis are shown. For this analysis, we recognized significantly elevated RNAs by log2 fold change over 1, p-value less than 0.01, and false discovery rate less than 0.05. The 12 RNAs such as CXCL8, G0S2 were upregulated in PDAC compared to non-PDAC, including healthy individuals and IPM patients. The slide shows the bar graph of extracted 12 RNA expression in non-cancer and cancer. Among them, MTND1 is only pseudogene. The other 11 RNAs are all messenger RNAs. Moreover, 4 RNAs such as MTND1, PTGS2, SOC3, and SPARC were found to be highly expressed in stage 1 PDAC. The diagnostic values of these RNAs evaluated by ROC curve analysis. The area under the curve, AUC for PDAC diagnosis ranged from 0.55 to 0.74 for each RNA. The AUCs of the combination of 12 RNAs and 12 RNAs with CA99 were 0.83 and 0.98. Next, the result of gene ontology analysis showed RNAs upregulated in PDAC were enriched in platelet alpha granule-related molecules. We also assessed the gene expression profiling in IPM patient with or without worrisome features. 5 RNAs such as APAF1, CCNH, found elevated in IPM samples with worrisome features compared to without worrisome features. Among 5 RNAs, 4 RNA expression was highly upregulated in serum from IPM patients with 2 worrisome features. We are not sure the association between worrisome feature number and these RNA expression because of the sample size is very small. But now we are trying to their correlations. Although there are several points to be solved, such as selecting RNA markers and establishing multiplex digital PCR, the analysis of nucleic acid in pancreatic juice could improve the diagnostic ability for early PDAC. Next, we didn't state in the abstract, but I'd like to show our project regarding the DNA mutation analysis. We also focused the initiation and progression of pancreatic cancer precursors. Pancreatic acinar cells can undergo to acinar to ductal metaplasia, ADM, that induces transdifferentiation into ductal-like phenotypes. Pine can be generated in mice through the expression of KRAS, oncogenic KRAS. Most of IPM thought to arise from ductal cells, and some of IPMs arise from acinar cells in association with KRAS and genus mutation. The subsequent inactivation of tumor suppressors such as TP53, SMAT4, and CDKN2A accelerates the progression of precursor lesions, leading to invasive ductal adenocarcinoma. Thus, not only RNA analysis, we have focused the analysis of DNA mutation analysis as liquid biopsy. In a recent data using cell-free DNA, we have investigated the possibility of collecting deodorant fluid, DF, containing the tumor cell or DNA through suction channel during EUS or ERP examination and try to detect the mutations derived from pancreatic tumor. The mutation concordance of liquid biopsy with tumor lesion or resected tissue or FNA biopsy were confirmed. In this analysis, we classified the concordance pattern into 6 categories. And following above 3 categories are concordance positive. DFDNA showed over 50% concordance with tissue mutations, whereas plasma cell-free DNA showed 24% concordance rate. In addition, recently we have reported the utility of pancreatic juice for the detection of mutation from primary tumors. Mutations detected with 50% in DFDNA, 90% concordance in PJDNA, compared to 25% in plasma cell-free DNA. PJ and DF are more sensitive than plasma as liquid biopsy samples for detecting the mutations derived from primary PDAC lesion. According to those data regarding the DNA mutation analysis, we are now proceeding to construct a system of multi-layer analysis with eVRNA and DNA mutation to apply the pancreatic cancer diagnostic panel as a liquid biopsy tool for blood, PJ, and DF. In conclusion, several PDAC-specific candidate RNAs were identified, and establishing an eVRNA and DNA mutation panel has the potential to improve the early diagnostic accuracy for PDAC. Finally, our project was conducted by those collaborating research institutes, hospitals, and companies. We sincerely appreciate the cooperation very much. Thank you for your attention.
Thank you very much, Professor Takahashi, for your great talks. So we'd like to go next. Next one is Professor Ajay Goel from City of Hope. And he's going to talk about biomarkers in pancreatic cancer. Please.
Thank you. Good morning. I would like to start off by thanking the organizers. So I'm going to go fast. Some of the things I'm going to say have been covered by the previous speakers. So these are my conflicts. So in terms of pancreas, I don't need to tell the common disease, poor outcomes, and projected to become the second leading cause of cancer-associated mortality in the US by the end of this decade. And as we know, most of these pancreatic ductal adenocarcinomas, they are not resectable when they're initially diagnosed. So that's a challenge. That's where the poor outcomes associate with. So only 15 to 20% patients of the patients have resectable disease. And why this is important? Because the 5-year survival is associated with a stage of diagnosis. So if you have a resectable disease, obviously the 5-year outcomes are much better compared to those who have late stage disease. So when it comes to pancreas cancer, just like many other cancers, this cancer does not evolve overnight. It takes from the first initiating KRAS mutation to the evolution of a metastatic cancer, it takes somewhere between 15 to 20 years for this cancer to grow. So that's why it is important that there is an opportunity that we can, if we have tools which are inexpensive, if we have tools which are simple, we can possibly start to use some of these blood-based liquid biopsies for earlier detection, earlier interception, and hopefully improve the survival of these patients. So what do we have in terms of biomarkers? Really not much in the clinic. We don't really use much. We use imaging. We use CA19-9. All of those have some value, but mostly in the advanced stage disease, but not in the early stage diseases. So really, we don't have good biomarkers for early non-invasive detection of this disease. As you heard from the previous speakers, when it comes to liquid biopsies, they're many choices. You can pick your favorite circulating tumor cells, RNA, DNA, metabolites, you name it. And these are some of the tests which are currently available, not commercially used, but these are available tests. When it comes to early detection of pancreatic cancer, you can see a CA19-9 still is the most commonly used marker. There are a few other tests by different companies in different stages of evolution, which are there, but most of these are not used for commercial purposes. And this is the performance. Just like I said, the most important thing is we have these tests, but the challenge is when you look at them, they don't work really in earlier stages of disease where we need them. So if you're doing early detection, we do not want a test which captures stage 4 disease. We want a test which can capture stage 1 disease, and that's where the performance is not really optimal. So we began to look at that most of these tests are based on either cell-free DNA or protein markers. And I think when it comes to cell-free DNA, there's a challenge. Early stage lesions do not release enough cell-free DNA to be captured. And some of these protein-based markers, they just don't have enough sensitivity or specificity. So we began to look at, can we use microRNAs? You heard from the previous speakers, long non-coding RNAs, and these are small microRNAs. Why? Because they're frequently expressed, they're very stable. You can use them from any sort of bodily fluids, and they come in two different flavors. They come as cell-free microRNAs, which means total microRNAs present in the blood, and then they come in extracellular vesicles, or EVs, which are exosomal microRNAs. So if you look at the literature for the last 10, 15 years, tons of work has been done on microRNAs, but much of the work is done on cell-free microRNAs, which are highly sensitive, but they do not tell you where the disease is coming from. So if you take a blood sample, analyze microRNAs, you would not be able to tell whether this microRNA is coming from pancreas or colon or some other body part. So that's very important. So we began to look at, can we utilize the advantage of using tumor-released extracellular vesicles or exosomes, which can capture the specificity of the disease. And that was the hypothesis, that we began to look at highly sensitive cell-free markers and highly tumor-derived specific markers released by exosomes in pancreas. And the idea was, if we combine the two together, we possibly have a diagnostic test which is highly sensitive and specific at the same time. So this is what we did. And this part was thankfully part of the NCI's funding. The NCI started this consortia called Pancreatic Cancer Detection Consortia. We are fortunate to be part of this. And this has been a work we have done over the last 7 or 8 years. We have 8 different sites in US, and we have 2 foreign sites, one in Japan, one in Korea. And the goal is to develop exosome-based liquid biopsy for early detection of pancreas cancer. So this is some of the work we published a few years back in gastroenterology, where we showed some early data. So the logic was, can we look at cell-free microRNAs and exosomal markers? This was done by sequencing. As you can see, that we are looking at patients with disease versus those who don't have disease. And we could capture very clearly a panel of exosomal markers and cell-free markers. So how do they perform? So we use machine learning to develop these panels, where we are looking at essentially regression models, and then we're stacking them with different analytic approaches to see how we can combine these markers to develop a blood test which can capture early stage disease. Here are the results. If you look at these 5 cell-free markers, they look quite good. If you look at the AUC values, it's 84, and for the exosomal markers, they're slightly better, 89. But the logic was, what happens when you combine the 2 sets of markers together, whether there's any gain in diagnostic accuracy, and that's exactly what we saw, that when we combine them together, actually the test looked pretty darn good for a blood test for pancreas cancer detection. But this was a relatively small cohort. We had about 125 patients with pancreas cancers, and we knew that we have more work to do. And just like I mentioned, we use CA19-9 in the clinic, so we wanted to see, would there be added value if we combine these blood-based markers along with CA19-9, and that's what we did. So here you're seeing the data that when we combine these markers along with CA19-9, actually the assay looked even better. So that was good, that we knew that CA19-9 is not perfect, but when combined them together, actually it looked much better. And in this case, we reached the AUC values of up to 99, which looked too good to be true, but it is what it is. So even in early stages, on the right side, you can see stage 1 and 2 cancers, we can capture them with quite high degree of accuracy. So this is all the data which was published. So the point is that even in early stage cases, we not only have high AUC values, but when we look at individual sensitivity and specificities, this test looked quite impressive. But we knew this is a small pilot data which we have from hundreds of patients, and we have more work to do. In addition to microRNAs, we look at some other kinds of non-coding RNAs as well. So this is just an article which we published, again, a few years back. We were looking at something called circular RNAs. So these are circular RNAs which are very stable. And the point was we can use some of these markers in addition to microRNAs as well for early diagnostics of this disease. And we are in a process now where we hope that eventually we'll have probably a combination of multiple types of markers together, which have the highest possible diagnostic accuracy. So going back to what I showed you, the microRNA work. So what we published was from about hundreds of patients. And over the last 2 or 3 years, we have continued to work on this. Some of this work was presented earlier during this year at AACR, led by Dr. Kai-Ming Hsu, who is in the audience here. So what we did, we expanded on this work now, where we have now actually data from almost more than 1,000 individuals. I'll show you. So this is the cohort. So we have now looked at the performance of this test in multinational, multi-ethnic cohorts. So as you can see here, we have about 600 patients with pancreatic cancers from US, from Japan, from China, from South Korea. And we have about more than 1,200 individuals altogether. So the goal was, what we published before, can be replicated? Is it really true? And not only it's true, whether it works in populations across the globe in different centers. So this is the data. So we have a training cohort. As you can see on the left, these are non-disease controls or healthy subjects, and we have broken down these into stage 1, 2, and stage 3 and 4. As you can see, these markers work quite good. They can easily discriminate between patients who have disease versus who don't. But not only that, we can look at very early stage disease. These markers did quite well for finding stage 1 and 2 patients as well. And these are the data from all 3 individual cohorts. In each case, the markers looked quite good. So if I show you the same data in ROC curves, now you can see the data collectively that the markers looked quite good in these almost 1,200 individuals across these cohorts. Even when we focus on early stage disease, stage 1 and 2 patients, the performance of these markers was quite impressive. Again, just like I showed you the example before, when we combine these markers, which we refer to as Panexian, along with CA19-9, the data looked good. I'm not showing you, but about 10 to 15% of the patients do not produce CA19-9. So they're CA19-9 non-secretors, and we were able to show that those who do not produce CA19-9, we could capture those patients as well using this blood test. Again, when we combine our markers with CA19-9, the performance improved even further. And the next thing was, are these markers specific for pancreas cancer, or they can capture other gastrointestinal cancers as well? So this is what we did here. So we're looking at patients who had either gastric cancer, colon cancer, liver cancer, squamous cell adenocarcinoma, and so forth. And what I'm showing you here is, yes, these markers are not exclusive for pancreas cancer, but they do capture pancreatic disease most robustly. So you can see very clearly that these markers were quite specific for finding pancreas cancers versus other GI cancers. So not only that, we were able to show that to understand the origin of these markers, we were able to get access to patients who underwent surgery, and we had access to their blood samples few weeks or few months after surgery. And what I'm showing you here is that once these patients undergo surgery and we analyze the markers we have discovered, we can see a significant drop in the markers, which tells us that once you remove the tumor from the body, the markers drop in circulation. So that demonstrates the specificity of the markers, that once you take the source of these markers out, these markers were quite good. And not only that, we can follow these patients now post-surgically and see whether these markers continue to track the disease or not. And that's exactly what I'm showing you here. Not only we can use these markers for diagnostics, but we can also use some of these markers for disease follow-up and response monitoring as well. So where does it take us? So what I showed you is, so these are the 3 different cohorts from US, from China, from South Korea. And this is the performance of these markers in individual populations. And also when we look at the performance of these markers in early versus late stages. These markers looked quite good, but they looked even better when you combine them with C19-9. So I think this is quite impressive that these are more than 1,000 individuals, and now we have a blood test which works quite robustly even for early stage disease. Just for the last couple of minutes, I'm going to show not only just microRNAs, you heard from the previous speaker as well. So we look at cell-free DNA methylation as well. This is some of the work we published a few years back along with Dr. Randy Brand and others. We develop basically a multi-cancer early detection test just for the GI cancers. And here's the data for cell-free DNA methylation. We're looking at colon cancer, liver cancer, esophageal, gastric, other cancers, and these are the markers in blood. We're looking at cell-free DNA methylation markers, and you can see that these markers work quite well, not only for all stages, but even for stage 1 cancers, these markers looked quite good. In addition, we can replicate the source of these markers in cell-free DNA, that if you trace back, we look at the sequencing, methylation sequencing in the tissues, we can correlate these markers which are present in blood back to the tissue. So that tells us that the markers we're looking at in blood actually were driven from the source of the tumor itself. We have also developed some novel techniques. This is a technique we call nano-5-methylcytosine sequencing. So this is one of the first methods which we use complete genome-wide methylation sequencing. Actually, this method became the source for recent FDA approval for allowing the first test for pancreatic cancer screening in patients with high risk. So based on this methodology now, we are expanding this work to see whether we can develop cell-free DNA methylation markers for early detection of patients with pancreas cancer. This is some of the early data where we can use these cell-free DNA methylation signatures not only for early detection, and also we have just published recently these 2 studies where you can do complete genome-wide methylation sequencing from as little as 100 microliters of plasma. We can do complete methylation profiling in blood, and we can develop markers for early detection of this disease. So just to summarize, what I shared with you, that we can use microRNA-based markers for early detection of pancreas cancer. We have done similar studies in colon and other cancers as well. And what I've shown you is that when you combine these markers in exosomes, there is a component of tumor specificity, which we can address if you look at these markers within the exosomes, which helps. We can use cell-free DNA methylation markers. And also some of the work I've shown you, a lot of these technologies have already been licensed to different pharmaceuticals and biotechnology companies, and we are in the process of doing prospective clinical trials to look at the performance of these markers in different populations. But the work is not done. We still have long ways to go. One of the biggest challenges in the pancreas world is going to be, even if there is a blood test, who are we going to use it on? We can't use it on everybody. We have to identify the right risk groups, patients who have the high risk. How we define that risk still needs to be worked on. How do these markers work in patients who have cystic disease or precancerous lesions? This is something we are continuing to think about. We're going to continue to work on this. What is the lead time? What is the earliest we can use this test before the patient develops symptoms? So these are all the questions which bother us. We are continuing to work on these. And hopefully, if I have to come back and share some of the work, probably in the next few years, we'll be able to answer some of these questions. And with this, I would like to thank all the collaborators who have helped make this a reality. And with this, I'll shut up. Thank you so much.
Thank you very much, Professor Goel. So now we have 10 minutes for discussion. So if you have any questions to each presentators, please come to the microphone.
Hi, Jennifer Vallerin from UCI Medical Oncology again. I guess my question, I think, is mostly for, is it Dr. Singh? Is that right? So if, I think that, of course, being scientists here, a lot of us are obsessed with fancy technologies, right? But, and the latest and greatest. But if we're talking about global health and also, equity of care, there was a study that was done about a year ago or a little bit longer looking at use of droplet digital PCR versus NGS for cyst aspiration. And if we're trying to be realistic about expanding these kind of testings to multiple different populations, especially with the conversion of IPMNs at such a low rate to pancreatic cancer, if you're being realistic about it, and requiring multiple testing. Digital PCR costs about $5 per sample. And even though NGS is much less expensive than when we first started sequencing, decades ago, to a couple $100, it just doesn't seem realistic. So what do you think is the gain of using a technology like NGS or looking at things like microRNA and these things over something simple like just digital PCR for KRAS and GNAS?
Just keep pushing on it. You can hear me now. I agree. I think the sustainability, even digital droplet is too expensive. I'm going to be honest with you. But what you need to do is centralize it. And I think that's the key. You can't have a million labs doing the same thing. It's not going to make sense. So one of our strategies has, well, one, we're an academic center. We're not a business unit. That's not going to happen. One of the great things about UPMC as a university is we're not in it to make the money for it. So we just need to cover our overhead to make sure that we can actually give patients care. And the whole point of Pancreas Seek was originally just to deal with UPMC patients, and that's it. And then it just became broader, and then such that we started doing other patients, and now we do it internationally. I still stand by that model system itself. It doesn't make sense to replicate everything everywhere. It's not cost feasible, and it's just not practical. To keep the cost down, though, it makes sense on a volume end as well. If you do it so many times in a day, the cost and everything, you buy in bulk, it gets the price down significantly to the point where we are doing something but quite complex in a very cheap fashion.
Thank you for the great talks. I'm Deeksha Kapoor from India. My first question is to Professor Singhi. What is the additional yield of using Pancreas Seek over clinical and radiological criteria that it would change offering surgery or the surveillance protocol?
So I don't like to put a test, and never should that ever happen. Do you put a test in isolation? You got to take the patient into literally as a whole. And so just looking at a test result and making a decision based on a test result is just an appropriate way to do it. You really have to take the patient as a whole, integrating radiology, integrating the patient, the age, other risk factors overall when it comes to surgical intervention or not. The same goes with even doing an EUS. Is it really necessary even to send for molecular testing? I think that the point of molecular testing will eventually have to start triaging and stratifying patients who need molecular testing. What are you trying to assay itself? And then how do you interpret that data? I think that right now we have a very structured report based on all these alterations that we identify and trying to give the gastroenterologist or the surgeon the idea of what to do next. But in the end, what we're going to have to do is something in the future, which actually, I don't know if Dr. Lennon's around, she had a phenomenal paper on pancreatology looking at other characteristics, integrating that into the molecular testing using AI. And I think that's the next step where gastroenterologists will start plugging in, is the duct dilated and what dilatation? Where is the cyst located, the size of the cyst, and plug that into the system to then visualize for eventually a risk stratification.
Thank you. My second question is to you, Professor Goel. That was an excellent talk. Has the technology been tested in normal individuals to assess false positives?
Yes, thank you for this question. So by false positives, I mean, have we done it prospectively in a blinded fashion? No. But our false positivity rate in at least the retrospective cohorts is under 10%.
Okay, thank you.
I just want to say we have about 4 minutes left, so brief questions and brief answers.
Yeah. Okay, just as a small question then, how would you follow up germline BRCA2 mutations with cysts? Because you touched upon a lot of mutations, but not on that one. So I was just wondering.
Yeah, so there was a nice paper from Nick Roberts that came out in Gastro a couple of years ago at Hopkins saying that there was an increased risk with BRCA2 variants for pancreatic cysts. And I do think that there is some risk. Certainly, we do a lot of things at UPMC on our patients that we don't do for other patients. And we have been doing germline testing in the background when we get consent. I haven't seen much in the germline area when it comes to patients with sporadic pancreatic cysts. Do we treat them any differently if they have a germline variant or not? I think that we do mentally because we know they're at risk, but as far as what to do with that cyst, I'm not sure if we can actually make any calls on that.
Thank you.
Okay, I'm Wei Liu from Shanghai Medical School, China. I'm a surgeon. I'm also doing the endoscopy, including ERCP in the US. My question goes to Dr. Chris Tan. So thank you for showing the nice demonstration of the RFA for the IPM and BD. Actually, we just tried photodynamic therapy for those IPM and MD or branch duct with patients with very old. They are over like 80 years old. They refuse any surgery, and we tried this photodynamic therapy, and found it's quite effective. We give the dose, and like 3 months later, we goes into per-oral pancreatoscope, and we see the nodule gone, and the symptoms of pancreatitis also relieved. So how do you comment on this technology on this IPM, who is not like candidate for surgery? Thank you.
I'm trying to understand. So how do we evaluate response?
Yeah.
There is so much echo that it's so difficult.
How do you commend the PDT for this IPM and IPM MD?
So
evaluation?
in terms of response, we do a MRI follow-up in 3 months, and many a times the cyst is completely gone with single round of ablation, and so much so that we cannot do a repeat EUS to really aspirate that area. But in case there is kind of a partial response, we do aspirate, we send for next-gen sequencing analysis. And subsequently, we follow the patient with a traditional standard follow-up. For a large cyst, typically it's imaging every 3 to 6 months. And over time, the cyst completely goes away or it stays behind. And if it stays, then we repeat ablation again. So in 30 of the branch duct IPMNs, we have done a second round RFA in about 9 of them. And that eventually ablates the lesion. And these are all done in an outpatient setting.
Thank you.
Thank you, Johanna Laukkarinen from Finland. I really enjoyed the session. Short question to Dr. Sinchi. As we are trying to, or if we are thinking of how to narrow the huge amount of patients for the analysis from the cysts, what would you recommend? Would you do it based on the cyst size, like let's say 2 centimeter, 3 centimeter, and the other point of being that if the patient has multiple cysts, is it enough to take the sample just from one of them? Thanks.
Yeah, those are really important questions. I always go back to Carlos. I don't know if he's here at the conference today, but Carlos had a nice paper in Gastro that showed 1.5 centimeters cyst was kind of probably the right spot. That was the sweet spot when it comes to FNA patients with pancreatic cysts. And so we follow that rule, actually. We take patients that have a 1.5 pancreatic cyst. Obviously, it has to be a patient that is going to be eventually a surgical candidate. You got to take that into account first as well. Is there a point even doing an EUS FNA is the first step.
Yeah,
but if it's
sure.
a 1.5 centimeter cyst, we'll sample that. Now, the question is, how many of the cysts should you sample if you have 5 1.5 centimeter pancreatic cysts in that same patient? That's challenging. I would go, or at least our group has gone as region. So take probably one of the more concerning, theoretically, the largest pancreatic cyst, either in the head versus the body tail, and then go from there. It doesn't exclude a concomitant adenocarcinoma for ever forming in these patients. Certainly, we know that can happen as well. These patients are at risk. There's some data, even for patients that have large cysts, multiple cysts, that might also be additionally at risk. And so I think that we still have to get to the point where we're going to be able to help stratify these patients based on a lot of other aspects, not just the cyst itself.
So we're out of time, but we have to allow that last question. You were standing there patiently.
Thank you. Nicole Massal, UAMS. I'm a cytopathologist, actually. And so my question is, I loved the way all these went together. The microscopy with the EUS kind of goes to the case that you presented, the IOPN. Typically from cyto, we usually think of those obviously having nice branching, oncocytic cells, that kind of thing. And in a small lesion like that, you would expect to, when you go in, get cellular sample in something like that, because we usually on cytology get cellular things with those kinds of things. So it's interesting that that didn't have, very many cells, because in those types of lesions we typically do, but
No, absolutely not.
it's
In our
interesting
experience of
that-
almost 200 patients across multiple countries, most cytopathology has missed it. And that's also agreement with Martha Pittman at MGH. That includes a number of places, at least Hopkins in their cohort as well. We've gone through theirs. Again, we sequenced a lot of patients when it comes to IOPNs because we identified those PRKACA and B mutations or fusion genes. And actually now there's new partners that we haven't described, but that was all back in 2020. And going back and doing molecular testing on fluid retrospectively, now we've hit 14,000 patients. I have to say that we're going to miss them.
Yeah, they definitely have cystic.
Thank you very much. You can discuss. And I want to thank all four speakers for terrific talks and for educating all of us and the audience for being so patient. Thank you.